Good morning, everyone, and thanks for joining us at the conference this morning. I'm here to talk with you about epilepsy treatments. So we will go over sort of a broad overview of different treatments available for different types of epilepsy. We won't have time to go into any of them in much depth, but I'll sort of give you the framework for how I think about this. First, we'll make sure that we're all on the same page in terms of definitions. So epilepsy is a disease characterized by an enduring predisposition to generate epileptic seizures and by the neurobiological, cognitive, psychological, and social consequences of this condition. So it's about a lot more than just the seizures themselves. The seizures are a symptom of the disease of epilepsy, but there's obviously a lot of cognitive, psychological, and social issues that go along with it as well. A seizure, on the other hand, is defined as a transient occurrence. So transient meaning not permanent, it comes and goes. Occurrence of signs and or symptoms that's due to abnormal, excessive or synchronous neuronal activity in the brain. So basically the brain cells are all firing together in a way that's not helpful. Experiencing a single seizure usually does not mean that you have a diagnosis of epilepsy, but in some cases it might. And again, we're not going to talk about that today. But roughly 50% of all folks that have a single seizure won't ever have another one in their lifetime. So it's sort of a coin flip when you do experience a first seizure. Epilepsy is a very common condition, and it can affect people of all ages. It's the fourth most common neurological disorder. About 1 in 26 people will develop epilepsy at some point in their life, and about 1 in 10 people will have a seizure at some point in their life. Each year in our country, in the US, about 150,000 new cases of epilepsy are diagnosed. And that happens most often in young children, infants or young children, as well as older adults, but it can happen at any point in a person's life. About 3 million people in the US are currently living with epilepsy. And despite our best attempts at controlling the seizures, about 1 out of 3 people will have difficult to control seizures, which are called drug-resistant seizures, drug-resistant epilepsy, or medically intractable epilepsy. I kind of think about treatment for epilepsy in these broad categories. The first one is, something that patients and families can help identify and do for themselves. So that involves some self-care and sort of thinking about seizures, identifying triggers for an individual's seizures and trying to mitigate those factors when it's possible. And then the other sort of 4 broad categories would be medications, surgery, devices, and dietary therapy. And we'll touch on all of these in order today. So first, we'll focus on trigger identification and mitigating those triggers. So some very common triggers that my patients tell me about are some of these here. So missed medications can be a very common trigger, and sometimes we brainstorm with patients and families on how to help stay on track. That can involve alarms on cell phones or using a pill box or things like that. Sleep deprivation is another big one, and certain epilepsy syndromes seem to be more sensitive than others to this. So trying to stay on track with sleep and maintain a normal, a regular sleep schedule is really important. When a person gets sick with a virus or a bacteria, and especially if they have a fever, they may be more likely to have a seizure. Stress is a big one. A lot of patients talk about stress being more likely to trigger their seizures. Obviously, we can't eliminate all of our stress, but trying to find healthy ways of coping with stress and having an outlet for stress is really important. For women with epilepsy, hormonal changes, especially around the time of the period or in the middle of the cycle when ovulation is happening, those can be more sensitive times for some people. And then drugs and alcohol can also be big triggers for some patients. So trying to avoid it completely if you know that you're very sensitive to it, or at least drinking in moderation can be very important. And then some medications can also trigger seizures, such as certain antibiotics and certain pain medications. This isn't an exhaustive list, and I'm sure that folks out there have other triggers that may not be on this list, but these are just some of the most common ones. So we'll move on to talk a bit about medications now. This is our mainstay of therapy and our first line for treating epilepsy. So we can talk a little bit about what we wish we had in an ideal anti-seizure medication, and then we'll talk about what we actually have. So in our ideal world, we would want a medication that was completely effective, didn't have any side effects, it wasn't costly, your body absorbed it very easily, it didn't interact with any other medications, it lasted a long time in the body, so you don't have to take it multiple times per day. When it's broken down by the body, it has breakdown products that don't affect your system, inactive metabolites. It's excreted readily, meaning your body can get rid of it when it's done using it very easily. And in our real ideal world, we would have medication that could prevent or cure epilepsy. And what we actually have is that we miss the mark on most of these goals with most of our current drugs, unfortunately. Certain medications might be completely effective for certain patients, but it's certainly a trial and error process for most people still. Most of our medicines will have some side effects or potential for having toxicity if the doses get too high for certain patients, or allergic reactions. The new medications, of course, are brand name for a certain number of years, so they can often be very expensive. We have variable absorption. Most of the medicines interact with other drugs, with a few exceptions. Some of our medicines have that long half-life sticking around in the body, so they don't have to be taken so many times per day, but most of them don't. Some of them have breakdown products that can cause other side effects. And we don't have any medicines that prevent or cure epilepsy, unfortunately. This cartoon is busy, and it's really meant to just sort of illustrate how many different ways we can try and attack the problem of epilepsy and the seizures from a cellular perspective. So this big green blob up here is one brain cell, and this line down here is meant to represent another brain cell, or two separate brain cells, I should say. And these little dots are the chemical messengers that go in between the brain cell that's trying to deliver the message to the next one, the next neuron. And these blue boxes are all of our different medications and the points at which they can act on that signaling between the different neurons. And so you can see that we have a lot of different areas. We can sometimes attack the problem from what we call the presynaptic neuron. So that's the brain cell that has the message and is intending to send it to the next brain cell, or send it to the muscle, depending on what level of the nervous system we're talking about. And there's lots of different channels here, and we have packaged messengers called vesicles that also have proteins on them that medications can interact with. And then on the side of the brain cells that are receiving those messages, we also have targets for our medications. So if you ever hear your doctor talk about trying to choose medications that work in different ways in the brain, this is sort of what they're thinking about. They're trying to choose a medicine maybe that works on voltage-gated sodium channels, and another one that works on the GABA system, and maybe one that works on these AMPA receptors. But this is kind of a picture that we have in our mind when we're thinking about what medicines might be good for a particular patient's epilepsy. And to that end as well, sometimes the options that we recommend and that we think about for people with epilepsy depends on the type of epilepsy they have. So in general, we have these two broad categories of epilepsy: focal and generalized epilepsy. In focal epilepsies, we think about the seizure starting in a more sort of restricted area of the brain or in a brain region, whereas with generalized forms of epilepsy, many times the seizures start all over the brain at once, or they involve large areas of both halves of the brain, both hemispheres at once. And in some cases, some of our medicines, like these listed under focal epilepsy here, are really better for focal epilepsy and either don't have a good effect on people with generalized epilepsy or sometimes can actually make it worse. On the other hand, we have a few medicines that are really only helpful in generalized forms of epilepsy. Like this one right here, ethosuximide, it's really only helpful for a very specific seizure type called absence seizures and can't really help other types of seizures. So you wouldn't want to prescribe that medicine to a person that has focal epilepsy because it's not going to help them. But as you can see over here, this big list on the left side, most of our medicines can really be effective for either type of epilepsy. And as you saw in that last cartoon, they can kind of work at all different levels of the signaling system in the brain. And so we just try to tailor the medication options to the individual patient based on a lot of factors like side effect profile, cost, seizure types, childbearing potential, things like that. Once a person has failed 2 medications that were appropriately chosen, meaning your doctor knew what kind of epilepsy you had, or at least had a pretty good idea and chose a medicine that should work for that, and you took it like you were instructed to, and you got to a dose that should help. If your seizures continue after 2 medications, then you may fall into this category of drug-resistant epilepsy, which, as we mentioned, is about 1 out of 3 people. And that's the point at which we have to start thinking about those other treatment options for epilepsy, because the chances of completely controlling the seizures with multiple other medication trials becomes much less, unfortunately. So now we'll just briefly talk a little bit about surgery for epilepsy. And this cartoon shows some of the different surgical procedures that can be available for some patients with epilepsy. Many of these are for focal forms of epilepsy. Most of the surgeries are for focal epilepsy, not generalized forms of epilepsy. And the reason is that a lot of them are aimed at either removing or disconnecting parts of the brain that are generating the seizures. So you have to have a part of the brain identified that might be generating the seizure. So one of the most common surgeries that's done is this, what's called an anterior temporal lobectomy, this purple area here, the temporal lobe being part of the brain that's kind of sitting behind the ear. And if seizures come from that area, and after many tests, the doctors determine that taking out that area may have a high likelihood of making the person free from seizures, they may have that area taken out. The frontal lobe is another common area where seizures might occur. And if we figure out where the seizures are coming from, and again, determine that taking that area out is unlikely to harm the person, then they may be recommended to have a part of their frontal lobe taken out. There's other surgeries that are sort of more selective, meaning smaller areas are taken out. There can be very big surgeries, something called a functional hemispherectomy, where the surgeon essentially disconnects the front and the back parts of the brain and may remove a large area. And this is sometimes recommended for children who may have had a stroke early in life. And so they have a large area of brain that is damaged and they have difficult to control seizures as a result of that. This one I won't talk too much about because it's not done very often at all, but multiple subpial transections is something where the surgeon can make very tiny cuts in an area of the brain that you cannot remove because it's got very important functions like the primary motor or sensory cortex. And then this surgery down here, the corpus callosotomy, is one that can sometimes be done on patients that have certain types of generalized epilepsy. This big bundle of fibers here, the corpus callosum, connects the right and the left halves of the brain. And by disconnecting that most of the connections between the right and left half, you can sometimes reduce the severity of seizures. This one does not make people seizure free, though, unfortunately. And then there's more minimally invasive options available as well, like this stereotactic laser ablation, where a probe is introduced into a part of the brain and it's heated, and it essentially destroys the tissue in that area. Or radiation can be also an option if you know where the seizures are coming from. A lot of folks still think of surgery as being a last resort for epilepsy, but because it's scary. If you think about having a brain surgery, that's a very scary thing for a lot of patients to think about. This trial done in the early 2000s, called the ERSET trial, looked at early surgical treatment for drug-resistant temporal lobe epilepsy, so a very specific group of patients, versus continued medical therapy. And so the patients that were included had temporal lobe epilepsy. They had failed 2 medications. They had seizures for 2 years or less. So these were folks that did not have epilepsy for a very long period of time. And they were randomly assigned to either the surgery or continue their medical therapy. It was hard to recruit for this study. And they planned on recruiting 200 patients, but over 4 years and 16 centers, they were only able to recruit 38 patients. And so the study was stopped early because of that. But despite these small numbers, none of the patients that were in the medical group, continued medical therapy, were seizure-free, but 11 out of 15 patients that were in the surgical group were actually seizure-free. So even though this study did not reach the number of patients it was originally planned to recruit, it still showed that the surgery had a much better chance of rendering people seizure-free than continued medications. And so we do recommend surgery, or we start to think about surgery, I should say, after patients have failed 2 medications if they have focal epilepsy. So it's not a last resort. It should be considered early, and that's when people need to be referred to an epilepsy center if they aren't already taken care of in one. So now we'll move on and talk a little bit about the devices that we have available for treatment of epilepsy. And there's 3 main devices at this point. There's the vagal nerve stimulator, the responsive neurostimulator, and the deep brain stimulator. The last 2, the RNS and the DBS, those are both brain implants. So that's a different type of brain surgery, but still a brain surgery. Whereas the vagal nerve stimulator is not a brain implant. The vagus nerve is a nerve that comes out of the brain stem and travels down in the neck. And it travels very close to one of the arteries in the neck called the carotid artery. And in this case, the surgeon attaches wires to that vagus nerve, and the generator, the battery pack, goes in the left upper chest typically. And the neurologist programs the stimulator to deliver impulses on a set schedule. So it may be on for 30 seconds, off for a minute, 24/7. And those messages travel up the vagus nerve into the brain, and over time reduce the number of seizures that many people are having that get this implant. None of these devices typically make people seizure-free. They are all meant to reduce the number of seizures, potentially reduce the severity of seizures when they do occur, and or reduce how long it takes people to recover from seizures when they get them. The responsive neurostimulator is, as I mentioned, a brain implant. And this one, you have to have a very good idea of where the seizures are coming from, because these strips are meant to represent electrodes that actually get implanted on the brain or in the brain at the site where the seizures are starting from. And this device reads the electrical activity of the seizures, and over time is programmed by the neurologist to recognize those seizures and give a small electrical impulse to try and interrupt that seizure activity. And this is, again, a treatment that takes time to be effective because over time, the neurologist, again, kind of learns from the device what the seizure pattern looks like, teaches the device to recognize that, and then programs it to try and interrupt that signal before it really has a chance to take hold. The deep brain stimulator is a stimulator in a device that goes into a very deep part of the brain called the thalamus. And so this one you do not need to know where the seizures come from in the brain in order to have this device. And the battery packs are demonstrated here in the upper chest as well. And this again gets programmed by the neurologist, and this also has some sensing abilities, so they can sense some of the electrical activity that's coming out of that deep part of the brain. And in some cases that may help the neurologist program this to try and treat the seizures better. But all of these devices typically have the potential for, reducing numbers of seizures, but unfortunately not making people seizure free. The vagal nerve stimulator, and actually the responsive neurostimulator too, these both have magnets. The VNS has a magnet that if a patient has an aura, or if they are with someone who sees them go into a seizure, they can put their magnet over the device and it will give an extra stimulation, which in some cases might be able to stop the seizure or shorten it if it's going to happen anyway. The responsive neurostimulator, when a patient feels that they have experienced a seizure, they can also place a device over their RNS that makes sure that that information is captured. And the DBS, similar as well, actually. It also has a sort of transmitter that can be placed to record information when a patient is having a seizure. So that can be reviewed by the neurologist at a later time. So now in the last part, we'll go on to talk a little bit about dietary therapies for epilepsy. A lot of folks have heard of ketogenic diets for various reasons. Some folks are using it for weight loss, or feel that it's just a healthier way of eating, or sometimes for bodybuilding. And but we also know that ketogenic diets can help reduce the severity of seizures in folks that have hard to control seizures. And this is an example of some foods that would be okay on the ketogenic diet, like eggs and ham or bacon. Probably not so much these English muffins here, but the eggs and the bacon for sure. There's a few different flavors of dietary therapy for epilepsy, and we'll talk a little bit about the first two, the low glycemic index diet, as well as the modified Atkins diet, which sometimes is also called a modified keto diet. There's also the classic ketogenic diet, which is something that kids under 5 will be started on, or adults that are fed through a tube are sometimes started on this as well when it's felt to be necessary. But we won't talk too much about that one today. And then I just mentioned intermittent fasting here with a question mark because I have some patients that have tried it or have done it, but there's not a lot of data at all about whether this is an effective treatment for epilepsy, or really how to guide patients and help them if they want to try intermittent fasting. So what is dietary therapy? It's a diet that limits carbohydrates, which are sugars are one type of carbohydrate, and it tries to provide fat as the primary fuel for the body to run on. So this, in the sense of a ketogenic diet, it transitions the body from running on glucose, which is sugar, to running on ketones, and ketones are the breakdown products of fat. So how does this kind of diet work? Well, the truth is that we don't really know. It probably works in several different ways in the brain, but these are some theories about how it may work. One way is that reducing glucose or sugar reduces the amount of fuel available to the brain to keep a seizure going, because seizing brain is very highly metabolically active, meaning it needs a lot of energy to keep going. And sugar is a very an easy source of energy. So if you reduce how much sugar is around, you may be able to reduce the energy available to keep a seizure going. Ketone bodies also enhance the activity of a chemical called GABA, which in the brain is what we consider to be an inhibitory chemical, meaning we have some chemicals that are excitatory, meaning it helps the brain fire more, and other chemicals that are inhibitory, meaning it sort of calms the brain down or quiets it down. So if we enhance the activity of an inhibitory chemical, we're enhancing the calming down effects of that chemical. They also decrease the activity of glutamate, and glutamate, on the other hand, is one of those excitatory chemicals in the brain. So it may help to restore that balance between excitation and inhibition. Decreased sugar also can make the mitochondria, which are the powerhouses of our cells, the energy producers of our cells, make them work better in the brain. And there's also some evidence that the ketogenic diet can change our natural bacterial makeup in our gut. And there's some very complicated connections between the gut and the brain, which may influence seizure activity in the brain. And then it may also reduce the potential for epileptogenesis, which is the ability to continue to make new seizure networks. So this plate here is sort of a standard American diet. What our government would say is a healthy diet. You want a quarter over here of grains, you want fruits, you want vegetables. And the truth is that most of these three things, a lot of that is actually carbohydrate, and protein is here in a little quarter over here. And then dairy, of course, also has sugar. Lactose, milk sugar is another kind of sugar. So on the other hand, when we start to think about some of these ketogenic diets, our typical American diet, as I kind of alluded to, it's a lot of carbohydrates, 50% or more, probably a lot of people are eating per day of carbs. And when you start to focus on a ketogenic diet, your carbohydrates go down to this little tiny sliver, and fat makes up a large portion of your daily intake. And then protein is probably more than you might typically eat in a standard American diet, but not as much as the fat. We really want people to focus on fat intake when they do these diets. Low glycemic index diet is one that was developed in the early 2000s at Mass General by a neurologist and a dietitian. It's actually lower in fat than that modified Atkins diet that we'll talk about next. About 60% of calories per day will come from fat, and a bit higher in carbs. And the glycemic index is a measure of what effect carbohydrates have on blood sugar levels. Not all carbs are made equal. Some are really rapidly absorbed and digested. And so they sort of spike your blood glucose, and then it drops really fast. And those are foods that are considered to be high on this glycemic index, whereas others you may digest more slowly. And so they have a more gentle effect on the glucose level in your blood, and they're considered low glycemic index foods. So this diet focuses on foods that have a lower glycemic index, typically 50 and under. And so this picture shows some foods that are considered lower glycemic index foods, as opposed to some of these foods over here that are high glycemic index. And the point is to try and get our blood sugar to do something more like this, where we're not having big fluctuations. A typical American diet, especially if you have a high carb meal, might have blood sugars that do this with this red line. And this is where insulin is released. Insulin is that chemical in our body that helps us to process the glucose that we eat. If you eat lower glycemic index foods, we think that the sugar does more of this, and this can be better for epilepsy. Modified Atkins diet, on the other hand, is a more restrictive diet in the sense that the carb goal is much lower. It's about 20 grams of carbs, whereas back here with the low glycemic index, it's about 40 to 60 grams of net carbs per day. And you can calculate net carbohydrates in a food by taking, if your package has a nutrition label, total carbohydrates, you subtract the dietary fiber, and that gives you your net carbohydrates for that serving of that food. We really tell people to increase their fat when we recommend this diet, and that their food should shine. Everything that they eat should be shiny because it's got so much fat on it. when we cut out carbs, we also have to kind of limit the fruits and vegetables that people eat, because that's got a lot of natural sugars in it, depending on the vegetable or the fruit. And so that may cut out some very important nutrients. And so folks need to be on a multivitamin or on this diet. And we also monitor labs on a regular basis to make sure the body's tolerating it okay. You need your liver to process fat. And so we need to make sure all of that is fine. When patients do the modified Atkins diet, they follow ketone levels at home, at least initially. And this is through a urine test typically. We can use this formula or these shakes to boost the fat intake of our patients if they need that. They work closely with our dietitian. We offer this for adults at U of R in a clinic 1/2 day per month. And the dietitian, Leanne Haben, is wonderful. And she really helps patients navigate these diets. And we generally check a set of blood work every 3 to 6 months, and we can maintain patients long-term on these diets. There are, of course, some potential side effects, and we aim to monitor and mitigate those whenever we can. But these are some of the more common side effects, with kidney stones being a more rare side effect, but one that we do watch out for. And I didn't put here, but I should put here, is high cholesterol. We also monitor for that, and very rarely have to start patients on a medication to manage their cholesterol. Most of the time we can manage that through their fat choices. And that is all I have for you on the treatments of epilepsy. I want to thank everyone for their attention. And of course, you all know that November is Epilepsy Awareness Month, and I welcome any questions at the end of the session.